I think we will get started. Welcome to today's media dialogue. It's titled COVID-19, Where Do We Go From Here? I'm Wayne Sharp, a health media specialist with the Internews Rooted in Trust project. And Internews is one member of the group hosting this dialogue. Last month we got the 5 most important things to know about the Omicron variant. In today's dialogue, we'll explore some of the possible directions the pandemic could take us from here and what needs to happen to get us on the right track in East and Southern Africa. We are joined by Dr. Otim Cossy Ramadan of WHO, who will talk about the 4 possible routes of the pandemic. And hopefully there is some room for optimism there. We'll also learn about Africa Check, a fact-checking service that journalists can use to sort out fact from fiction in reporting on the virus. Of course, our main goal, as always, is to answer your questions. So please type your questions in the chat box, and we'll be sure to ask them of our experts today. Co-moderator Tole will monitor the chat box during the talks, and he'll share the questions with the speakers during the dialogue. Okay, so now let's welcome Dr. Otim Cossy Ramadan. He's a regional epidemiologist and the focal person for COVID-19 response at the WHO Emergency Hub in Nairobi.
Thank you very much. Thank you very much, Wayne. Good afternoon, colleagues, the different time zones that you are in. I'm glad to join you on this dialogue, and I would be speaking about the COVID-19 pandemic. Where do we go from here? I think from the onset, I have to make 2 disclaimers. One is then that the COVID-19 pandemic has really been very, very unpredictable. And a number of times we've got it wrong on this, and sometimes we've got it right. So we've tried as much as possible to make educated guesses based on the knowledge we have accumulated over the last 2 years, and also the data that we have accumulated over the last 2 years. That's the first. The second is then that this pandemic is far from over. I think the notion that it's over is really not right. And therefore we need to continue to treat it with the seriousness that it deserves. So I will, if you can move to the next slide. So I wanted to start by saying, where are we now? So we definitely are 2 years deep into a continuous response to the pandemic, and most of the healthcare workers in the region have really not rested. They have been moving from wave to wave. For us in Africa, we are just emerging out of the 4th wave. Some sub-regions actually, like the East Africa, we're emerging out of the 5th wave. But generally, as the African region, we are emerging out of the 4th wave. You can see the graph up in red, just showing we had a 4th wave with the highest peak compared to the previous waves. The good thing then is that within the 4th wave, the hospitalizations and deaths have been less than the previous waves. But as we see now globally, Omicron is the dominant variant that we have. I was actually just checking, in the last 30 days, out of the close to 500,000 sequences that have been uploaded into the global GZ database, 99.5 of them is Omicron. So Omicron definitely has established itself. But we are also beginning to see the sublineage BA.2 beginning to take over in our sub-region as well. And maybe in the next 2 to 3 weeks, it may become the dominant one as well. But also the good news is then that access to vaccines and therapeutics have improved. In our region, I think now the challenges we had last year with vaccines is not as much as it is now. So access to vaccines has improved greatly, which is a good thing. For instance, we now have 6 countries that have vaccinated over 40% of their population. We have countries that are well on their way to achieve, at least also 5 countries that are well on their way to achieve the 70% target by June. There are other countries, if we scale up, that should be able to reach that. We have still 15 countries that have vaccinated less than 10% of their population. And so that is a point of concern. There was an interesting study which was just released on 2 weeks ago on the 12th of Feb, which tried to estimate the seroprevalence in Africa. It based on different studies from different countries, and it shows that generally in Africa, over 65% of the population have some level of antibody, either from infection or from vaccination. So this is a high number. Of course, I must state that this number is not homogeneous across the countries. It varies from urban to rural. So urban areas have high and rural areas have low. But there is definitely high level of population immunity within the continent. And our knowledge has improved. But the tricky part of this is that the population is fatigued. And we must not forget that the population is fatigued of all the measures, and the healthcare workers as well are fatigued. So this is where we are. So where do we go to next? If you can go to the next slide, please. So we have looked at what are the possible things that can happen within 2022. Of course, it's difficult to predict, like I said, but there are a few things to consider. We had looked at the fourth wave will definitely come to an end in the first quarter. In our sub-region, all the countries have seen decline in the last 6 weeks, successive decline. Globally, out of all the WHO regions, it's only one region which is reporting increase, so all the other regions are going down, so which is good. There is a high possibility of having a new variant, and this is the one that throws a spanner in the work, because we are still having transmission. Last week, globally, we had 10 million new cases. We had 60,000 deaths. So this is still a lot. And for the virus, as long as you have this kind of transmission happening, the ingredients for the emergence of a new variant is very, very high. Now, our concern is then when we get a new variant with the ability to evade the antibodies and also the antibodies due to the infection and vaccine, which means then it will become a virulent one and we get more severe cases and deaths. But it is definite that COVID-19 is here to stay with us. It's going to become endemic. And the endemicity, we will have to define it. We have not yet defined what that endemicity will mean. It is going to vary by country. What level does a country accept to be an acceptable level of transmission? Like for malaria, for instance, we have different countries with different thresholds of endemicity. So we may have to do the same for countries and say what level of transmission can we say is okay for Namibia or is okay for South Africa, and they can be able to go on with normal. But the fact is then we will be having these periodic resurgences. And of course, the issue of the waning antibodies, which will then require several boosters of the vaccine for both those who had a previous infection, but also for those who have been vaccinated. Next slide, please. Next slide. Yes, so WHO has looked at the data that we have, and we've tried to do some predictions based on the data that's available for the region. And there are 4 possible things. The first one then is that we continue to have a status quo like where we are now, sustained transmission at relatively low levels with the few spikes here and there. We have seen some of the spikes are driven by things like schools reopening. When you see schools reopening, then you see some spike in transmission. So that is one of the scenarios, but we see this as being highly unlikely. That's the first one up there, scenario number 1, status quo. Scenario number 2 is where we see increased reinfection, maybe up to 40%. So I mentioned earlier that we are seeing a significant increase in the population immunity. But then also we get to see people becoming reinfected, both as a result of the waning immunity, but also as a result of some of the variants that are able to escape the immune response to some degree. Now, if you have the reinfections happening in the context of, 1, that we have improved vaccination coverage, and because of the improved vaccination coverage and the reduced hospitalizations, sorry, I have this interruption. So we will have the governments beginning to relax their measures because not many people are going to hospitals. And because of that, you will have increased exposure, and therefore the reinfections will happen. Now, if we over-relaxed our measures, then we are going to likely end up with scenario 3, where you have very, very high reinfections, up to 80%. So if we do cautious relaxation of our measures, we may have some level of reinfection, but it will not be so much. So it can allow the systems to continue to perform effectively. But if we over-relax, and like people are saying, no, COVID is done, and we throw caution to the wind, then you will have, in the absence of a new variant, you will have significant reinfection going up to 80%. The only good thing with reinfection is sometimes you don't get severe disease like primary infection, and therefore the impact on the health system may not be much. And the last one then is the worst case scenario, which we are not praying for, is when we get a new variant, which is able to escape the immunity that we have, and therefore able to put more people to the hospital. So we think most likely we will have a mixture of scenario 2 and scenario 3. And in scenario 2 and 3, we will have repeated peaks of transmission, largely driven by reinfection, but also driven by some of the factors such as relaxation of public health measures. So now we have to watch out for scenario 4, because like I said, as we have this increased transmission happening globally, over 10 million cases every week, that is enough breeding ground for new variants to emerge. Next slide, please. So I think the priorities then, where do we go? The priorities remains we continue to mobilize communities to sustain the public health and social measures as new normal. There are measures that we can relax. There are things that we need to keep as part of the new normal, up to a point when then we think it is very, very safe to drop everything down. Because the moment we take every measure away, we allow the virus to freely move, then we create the environment for new variants to emerge. So the community engagement, the risk communication, to continuously tell the people that the risk has not gone away is very, very important. The second one is then scaling up the vaccination. It's very important that we take up the vaccination coverage to 70% and above. In most of our countries, we have set this target that by June, we should reach 70%. There's a lot of work still to be done. And I think the media and everybody have a function to play in this. For the high-risk groups, the booster doses remain important. And then, of course, supporting the regional institutions that are doing vaccination production, like in South Africa, the factories that are being established as part of that mRNA hub, those are things that we need to support so that we have steady supply of vaccines that can meet the demand for both the primary series of vaccination, but also the booster doses that need to be done. The third one is surveillance. You know, as cases have gone down, the testing has gone down. Now, when testing goes down, we are flying blind. We don't know what's happening outside there. We cannot do sequencing because you sequence the material that you get from people who have come to test. And therefore, you cannot know if there's a new variant that has emerged. So it's important that countries strengthen surveillance, people continue to test, and then we can be able to monitor what is happening in terms of emergence of new variants, and we can be able to detect and quickly respond. The last slide, I believe. Now, strengthening of health systems. COVID-19 has shown us that we were not ready, and we have been trying to respond ad hocly to this, but we cannot continue in that ad hoc manner. So a number of the COVID interventions need to be integrated into existing public health systems, but these public health systems need to be strong enough to be able to take them in. For instance, the COVID vaccination needs to go into, at some point, into the routine immunization program so that anybody who wants to get a vaccine can get it anytime. The testing needs to be part of the regular testing so that if you want to get a test, you can get it as quickly as possible. and then the ability to manage the cases, the supply of oxygen, and all these things need to be there. It's not something that we do once off and then we retreat, because the virus is still with us and it has not gone away. Issues like home-based care, sustaining the critical care services is very important. And then, of course, ensuring that the other services are being continued. We have seen in this response the issue of hypertension, the issues of diabetes. We need to scale up our capacity to screen and put people on treatment and make sure that the diabetes is controlled and the hypertension is controlled. So our boss has always, Dr. Tedros has been pushing and saying that the health system and health emergencies are two sides of the same coin. So we need to build a resilient health system so that we can be able to respond to. And of course, the last one, which is very important in our region, we have seen Madagascar, now we see Malawi. We have other emergencies that are coming up, and the countries cannot afford to continue only focus on responding to COVID. There are other public health emergencies that are important. So the countries then need to be supported and to be able to do integrated response, what we call all hazard response, so that they can be able, like now in Madagascar, managing the effect of the cyclones and managing the public health consequences, as well as responding to COVID. And these are things that realities that we have to. Some of our countries are seeing the impact already of malaria, for which the programs had fallen behind because of the COVID. So they need to be supported to manage these diverse public health issues that are there. So in conclusion, has COVID gone away? No, it is still here with us. What are we likely to see? We are likely to see that we are moving from the acute phase of the pandemic to a more protracted response that requires us to balance between delivery of the existing health services, but also keeping our eyes on the COVID so that it doesn't sneak again upon us and result in significant hospitalization and deaths that will overwhelm the system. So we are not yet out of the woods, and the work of continuously educating the population to keep their guards up remains a priority for all of us who are stakeholders in the provision of health. Thank you.
Thank you so much, Dr. Ramadan. That was an excellent.
Thank you very much, Dr. Otim. Ladies and gentlemen, ladies and gentlemen, you can put your questions on the chat. I see there's a hand from Ben Bella. You can put that question on the chat. And so far we have Patrick Mfaka from Malawi. He's asking, what are the chances of coming up with a vaccine that does not require boosting? Dr. Otim.
Okay, thank you. So in terms of the WHO research framework, the development of a pan-coronavirus vaccine is something that is already on the table being discussed, so that we have a vaccine that is able to address the different even types of coronaviruses, but also then for this one that can be able to address any subsequent variant that will come up. But you know that having that kind of a vaccine is not easy, because for you to be able to have one that will address all the different types of the coronavirus or even new variants that will come up. So there's a lot of research, and it is one of the areas that has been prioritized for the R&D, for the research and development team. And they are encouraging manufacturers to look into this aspect so that we will have one vaccine that addresses current variants and future variants, though it is very, very difficult to predict how the new variant will look like. But if they're able to identify an antigen within the virus that doesn't change so much, which they can target with the vaccine, it will be a very, very useful tool. Thank you.
Thank you very much. We have another question from Katie, who's asking, how do countries proceed if they have given out the first dose of AstraZeneca and they don't have enough doses of the same population for a second dose? Case in point is Malawi. There are more than 1 million people who got the first dose, but there is no more supply of AZ for the second dose. How should they proceed? Thank you.
Okay, thanks. So Of course, there have been guidelines that have been coming up in terms of the mix and matching, the heterologous administration of vaccines. But I think the first thing, if these vaccines were supplied through the COVAX facility, I believe arrangements are being made to supply, because previously there was a shortage of vaccines. But I was just looking at the latest updates. Shortage of vaccines is not a problem as it stands now. And actually COVAX is changing their strategy. Previously, they used to just push the vaccines to countries. They are now changing the strategy so that the countries request. So it's now based on demand and supply, so that they request for what they require. So what I have not, I am not very comfortable stating is whether within the portfolio of vaccines available now with COVAX, if AstraZeneca is enough. But I think the other option is that within the COVAX mechanism, there's always a possibility to move vaccines from one country to the other, provided they were supplied by the COVAX, and then the country can be able to use. So the third option then is the regulatory authorities within country are able to guide whether somebody who got a dose of AstraZeneca can get a second dose of say, a second dose with Pfizer or the other available vaccine. I know for sure some countries have issued that guidance, South Africa, for instance. So the national authorities can be able, in line with the guidance that is there from the WHO Strategic Advisory Group on vaccination, to make those recommendations. So I believe there are enough tools now, and it will not be prudent for people to wait very long to be able to get their second dose. Thanks.
Thank you very much. We have a question from Benbella Dekta, who's asking, is WHO looking at rolling out a rapid AGRTD? How accessible will those kits be so that populations can be able to know their COVID statuses on real time when they so wish?
Okay, so I think the person is talking about the self-testing using the antigen rapid tests. I think it is something that is being considered, and colleagues, we are trying to work on guidance for that. Some countries have rolled these out. There are two things that are usually challenging with this. One, of course, is the skills and the literacy level of the population. Are people able to read the instructions correctly of the kit so that they can be able to use it? The second one has been around reporting. When people use these kits in the community and then they test positive, because COVID is still in all countries a notifiable condition. So how do we capture those who test positive while they are testing at home? So those are things that the colleagues that work on the diagnostics have been looking at. I know for sure that there's a guideline that is being developed. And then the third thing will then be the issue of the affordability of these kits. I am not quite sure if we'll have sufficient funds to be able to procure this for everyone in all countries, but I think that is something, some engagement with the governments will have to be done to see how the costs can be subsidized and the tests can be readily available, provided there's a framework for ensuring that the tests are done correctly and they are reported and recorded in the national tally.
Thank you very much, Dr. Otim. We still have a number of questions, so I don't think if you'd mind if I shoot like 3 before we move to the next speaker.
Yes.
So the first one, how will the WHO help countries like Uganda, where many people have defied vaccination, of taking more than one injection? So they prefer J&J, which is not available. The country cannot provide to the majority of the population. How would WHO deal with this? Another question, they're saying, since COVID-19 keeps on mutating and available vaccines cannot guarantee protection, what is WHO doing to build a confidence among people who have received vaccines and are still catching the virus? This is Anyar from Southern Sudan. And there is also a question on the debate that has just emerged. mRNA vaccines may be changing the DNA. How true is that? Thank you.
Okay, I'll address 3 questions. So the first one for the colleague from Uganda. I think the benefit we have had with having very many vaccines in the toolkit is that people can get to make choices. I think the issue that we have to try to address is to make sure that these choices are available for people in countries so that they can be able to use them. I know for sure that there is J&J in Uganda. I don't know how much quantity is available. And one of the things I mentioned that COVAX is trying to do now is then instead of pushing whatever vaccine is available, as their stockpile improves, they work with countries so that the country requests for the type of vaccine and the doses that they need. So instead of probably Uganda getting Pfizer, they could request, then they get more J&J, which the population is preferring and they're able to use. It has been previously that this stock was not sufficient, it wasn't available. And we are thinking then as manufacturing capacity in Africa increases with the facilities in South Africa, the J&J would become more readily available and countries can be able to stock more of J&J and use it. So that is what is being addressed. And we hope then more vaccines can come in and people can be able to choose the one which is freely available for them. The question of my brother from and fellow countryman from South Sudan. So now building confidence among the people who have received the vaccines and are still catching the virus. Now, I think we need to state the truth and continue to state it, that these vaccines were not designed to prevent infection. So they do not prevent infection. Their efficacy was tested on preventing severe disease, the risk of hospitalization, and that's what they have been contributing to. So, and we have sufficient data now to show that a number of the people who have gotten vaccinated, when they get infection for the second time or so, it's really mild. So the virus has cut the chance for, the vaccine has cut the chance for this person to end up in a hospital and where they will be fighting for their life and die. So that is the intention of giving this vaccine, so that people don't develop severe disease and they don't die. So the message should be on that, which is the fact of the vaccine, not on the issue of testing positive. So you can test positive, but you don't end up in the hospital. And if you don't end up in the hospital, the vaccine has achieved the purpose for which it was intended. Now, let me link that up to the next question on the vaccine changing people's DNA and the mRNA question. Now, the messenger, and I always explain this, the messenger RNA, the way it is designed and the way the human DNA is stored, they are in 2 different locations. That is the biology that cell biology that they used to teach us. So the human DNA stays in the nucleus, and the proteins and the messenger RNA, they stay outside in the cytoplasm. So when the vaccine is given, it enters the cell and goes into the cytoplasm, and it produces the relevant proteins that is required from there. So it never crosses to the place where the DNA is kept. So it has no way to interact with the DNA because the DNA is kept in the nucleus and not in the cytoplasm. So that is a simple biology. And that is the fact with the mRNA vaccines. They have totally no access to reach the DNA, and they do not alter the DNA in any way whatsoever.
Thank you, Dr. Otim, very much. And now back to you, Wayne, to introduce our next speaker. So ladies and gentlemen, you can still put your questions on the chat box. And after the second speaker, we'll go back to an open plenary. Thank you, Wayne.
Thanks, Tole. Yes, now I'd like to introduce Naledi Mashishi to tell us about Africa Check. Africa Check is the continent's leading fact-checking organization where Naledi trains African journalists on verification and research techniques. She holds a degree in journalism and media studies from the University of Witwatersrand and a degree in journalism and media studies and politics and international relations from Rhodes University. Naledi, welcome to Media Dialogues.
Hi, thank you so much for having me on here. So I'm just here to do a quick run through of what we do as Africa Check, what the challenges we faced during the pandemic have been, and what you non-partisan fact-checking organization. This meeting is being recorded. Okay, that started in 2012. We have our main office is in Johannesburg, South Africa, but we also have offices in Kenya, Nigeria, and Senegal, publishing reports verifying claims made in and about Africa in both English and French. So we fact check claims made in the public domain, meaning that we verify statements made by public figures, and we also fact check posts that have gone viral on social media. We consult the best publicly available research, and we consult experts for important context and analysis. So all of the sources of information we use and the people we speak to are identified so our readers can verify the accuracy of what we say. And we also aim to use publicly available information because the whole point of our fact checks is that anyone should be able to follow the exact same methods we did and come to the same conclusion we did. And this is to help ensure transparency. So we publish reports and we also publish guides, which are resources to help journalists and the public become better fact checkers. We publish fact sheets, which are easy to understand summaries of important topics. And we publish blogs, which provide commentary and analysis of factual and statistical issues. We also run awards and training programs to promote fact-checking skills among the media, business, civil society, and the public. So I began with Africa Check at the beginning of 2020. So I started as a fact checker right at the beginning of the pandemic. And so I was kind of thrown into the deep end. And so some of the challenges that we faced throughout the pandemic, one of the biggest challenges, I would say, has been the spread of unverified content on social media. We've particularly seen this on Facebook and on WhatsApp. So I think it was Winston Churchill who said that a lie gets halfway around the world before the truth has a chance to put its pants on. And that is definitely what we've seen on social media. Social media has meant that it has never been easier to share unverified information. And so we see a lot of unverified claims flying on Facebook and WhatsApp in particular, especially from WhatsApp groups. And we've seen a lot, and we've seen this particularly in the case of unverified cures like ivermectin. A lot of the claims we've seen about ivermectin curing COVID-19 have appeared first on WhatsApp and Facebook. And there was a while at the beginning of 2020 when Madagascar was developing an Artemisia-based cure. And we were seeing a lot of claims on social media about how people could go into their gardens and get Artemisia to protect themselves against COVID-19, despite the fact that there isn't really data to support the claim that Artemisia will protect you against COVID-19. So a lot of those types of claims we see on social media. And in order to address those, we have created our WhatsApp channel called What's Crap on WhatsApp, where users send us viral WhatsApp messages and we fact check them. And we've also partnered with Facebook as a third-party fact checker, and we rate viral posts on Facebook for them. The second big challenge we faced has been resistance to fact-checking efforts from habitual misinformation spreaders and a distrust of accurate information. What this means is that people who habitually spread misinformation, it's really difficult to get factual information through to them. They tend to be very distrustful of sources that spread accurate information. For example, they tend to be very distrustful of mainstream media. They also tend to be distrustful of us. For full disclosure, Africa Check has received some funding from the Bill and Melinda Gates Foundation. We received this in 2020 and I think 2021. And so there are some people who will use this to discredit our efforts. So it can be really difficult to get through to those people. And we found that the sort of bar for factual information that convinces them, it tends to be quite high, which can be an issue in an environment like the COVID-19 pandemic, where scientists are continually finding new information. And as some of the information we had a couple of months ago might change a couple of months later. For example, there was a stage where the WHO said there wasn't really a need for people to wear face masks. And then that changed as we got more information on the pandemic. So, this is no one's fault, but it can make it harder to convince habitual misinformation spreaders that the information that they're spreading is inaccurate.
stopped.
I would say that before
This meeting is being recorded.
Okay. I would say that by November, December, we were starting, the claims around 5G and COVID-19 were starting to die out on social media. But the second he came out and said this, and said that COVID-19 was spread by 5G, we started seeing a reigniting of these claims on social media. There was also some attacks on 5G towers in South Africa, and we had to work hard to combat information that we had already, misinformation that we had already combated, and it made it that much harder. So, you know, the role that public figures can play in spreading misinformation really can't be underestimated. And I'd say that another big problem has been other media organizations. We've seen a massive problem of media organizations writing sensationalist headlines in order to get clicks. And
Recording has stopped.
a group that
This meeting is being recorded.
that was testing a vaccine candidate in Australia, and the vaccine was triggering an immune response that created the same antibodies that one would pick up in an HIV test. So these test subjects were actually were having false positive HIV tests. But the sensationalist reporting around this created the false misconception that COVID-19 vaccines were giving these people HIV. And so when you get something like that being created by news organizations, it spreads on social media, it spreads on WhatsApp, and you get a whole lot of people saying the vaccine will cause HIV. And you know this is true because this is what news organizations have been reporting. So this is what you can do as news organizations. The first is that I cannot stress the importance of getting accurate information out the first time. Studies have found that it's harder to combat misinformation once it's been spread. And so making sure that the information you publish is accurate is crucial to curbing the spread of misinformation. By plugging knowledge gaps, we call them knowledge gaps, with accurate information, you can prevent misinformation from forming at all. So it really is very important to ensure that the information you're publishing is accurate. While we understand that in the world of journalism, there is an importance that is placed on getting a story out first, getting the story out right is actually more important, especially when it comes to an issue like COVID-19. The second is to double and triple check all your information. So one issue that we've noticed is that sometimes, especially when it comes to COVID or on the continent, is that a news article will see that another news article reported something or quoted someone as saying something, and then just copy paste that information. Please make sure that you verify all the quotes you get from sources, especially from official sources. And also use tools like Google's reverse image search tool. So if you see a picture on the internet and it's being credited to, and there's a caption that's saying it's from some event somewhere, you know, just save the image, go onto Google Images. If you look on the Google Images tab, you will see an image of a camera, and you click that camera, and then that'll allow you to upload the image that you want to check, and it'll allow you to reverse image search that image and make sure, because what we see a lot of at Africa Check is old pictures being taken out of context with new captions that aren't accurate, and then those get spread as misinformation. So just double check all the images that you use. And a way that you can check videos is you can screenshot a still from a video and perform the same reverse image search, because it's an issue with videos as well. We've seen a lot of cases of videos being taken out of context with brand new captions, and that being used to spread misinformation. And also just, you know, verifying things for yourself. If you see someone reporting on a study, it's better to find the original study and read it yourself. Most studies, I found that most studies around COVID-19 have been available online, but if you find the original study and it's behind a paywall, you oftentimes can email the researcher, one of the researchers on the study, and ask them for a copy of it, and many times they will send it to you. So just make sure that you don't report anything you haven't seen and verified for yourself. And while we are on the subject of studies, please do be careful with studies. So what we found has been a big problem has been people taking a study and kind of reporting on it out of context. So for example, I fact-checked a claim that scientists had found that cannabis could cure COVID-19. I went to the study, and that's not really what they had found. They had tested cannabis products on tissues, so not on the human body, but on tissues that were replicated to be like human tissue, and they'd found that it could have some benefit, but it hadn't been peer reviewed. It needed additional studies. And so you need to be careful with taking those kind of studies and like check what methods were used in the study, and also what
This meeting is being recorded.
And what the study group size was. You know, if there were only like 10 participants in the study, then you need to ask some questions. It's not really a credible study. And it's also really important to see what the scientist's conclusion was. You know, scientists saying something may benefit COVID-19 patients. It's not the same thing as scientists saying that this thing cures COVID-19. And it's also scientists, if you can't get a quote from the scientists just to contextualize their findings and to provide further commentary, that can be really helpful. I know from personal experience that they're often really useful when it comes to getting additional information on their studies. So just try and get comment from them if possible, especially if you're struggling to understand the findings of the study yourself. Always ensure that you are using verified, reputable sources such as the WHO, the CDC, the African CDC, and other health bodies. You can also look on our website, which is africacheck.org, or you can follow us on Twitter at AfricaCheck to see if we've written on the topic that you are looking into. Another source that I love to use is The Conversation, because they write articles written by actual researchers in accessible language, and they link to all their studies. So they're another really great organization to look at for a source. And finally, at Africa Check, we always stress the importance of meeting people where they are. By that, we mean we try to make sure that the language that we use is written in plain English. We try not to use jargon. In cases where it's not really possible to get around jargon, for example, if you're talking about mRNA vaccines, you can't do that without talking about mRNA. So make sure that you explain what mRNA is in plain language. Another thing that we try to do is, even though the languages that we publish in are predominantly English and French, if we are fact-checking a post, and that post was originally written in like Afrikaans or Zulu, then we'll publish the fact check in English, but we will also then translate that fact check into the language that the claim was originally written in order to make sure that that audience is able to access the reputable information as well. And so, yeah, that's all I really wanted to say. Please just, I cannot once again, I cannot stress enough how important it is to make sure that during a time like this, we do our part to spread accurate information so that people are able to make the best possible decisions for themselves using the best possible information.
Thanks so much, Nility. Absolutely excellent. I have questions for you, and we have more questions in the chat box, but before we get to our next round of questions, I'd like to introduce to you the new video from Viral Facts Africa. Viral Facts Africa is your home for accurate fact-based health information. They work with fact checkers and health experts across Africa to debunk misleading health claims. In the latest video, which is available, I'm going to hand over now back to Tole. If he can press play on that video, we'll have a look. There you go. I think before I hand back to Toli, I just have a question that I think could be answered by perhaps both Naleda and Dr. Ramadan. You mentioned studies that have not been peer reviewed, and this throughout the COVID pandemic, mainstream media have been continually referring and reporting on reports that are not peer reviewed, and I don't remember seeing that happen in the past with other health crises. And it's because everything was happening so fast, and I think the media was looking for what was new and maybe seeing some good news on the pandemic. Is this a dangerous new trend? Both of you think that we're now seeing non-peer reviewed studies being presented out there and publicized without any knowledge that they actually are going to turn out to be scientifically sound?
Yeah, and if I may add on that, there's a question which is similar to that. It's from Odhiambo Kennedy. He asks, which mechanisms has WHO put in place to curb this kind of misinterpretation of some of this research that is coming out and is out there? You can have that and then we'll have all these other questions. Please go. Thank you.
I think maybe I can speak to the first part of the question. So I don't want to completely discredit any studies that haven't been peer reviewed, especially when it comes to a pandemic like COVID, when we were still figuring out things very quickly and there wasn't much known about it. So peer-reviewed studies can sort of be useful, but they have to be reported on in a way that is responsible. And reporting on them in a way that's responsible means acknowledging in the article that the study has not yet been peer-reviewed, the finding and what that means. And also, how you do your headline is important, because if you find a study that hasn't been peer-reviewed that, I don't know, claims cannabis may be beneficial to COVID-19, and then you go and you publish, and then you go and you say that in the article that the study has been peer-reviewed, but your headline is "Scientists find smoking weed can cure COVID." You need to remember that a lot of people don't read past the headline, and so if you have a headline that is misleading, then regardless of what the content of your article says, you are still spreading misinformation. And so it's very important that you make it clear in your headline and in your article that this study hasn't been peer reviewed. And also just question what the value of publishing a study that hasn't been peer reviewed is. We could argue at the beginning of the pandemic when we still didn't really know anything, a study that found, for example, masks could reduce COVID-19, even if it wasn't peer reviewed, you may be able to argue that it may have been in the public interest to report on such a study. But at this stage of the pandemic, that may not be such a strong argument. So it's really important that you use your discretion and that you be responsible about it.
Thank you. I think I can come in on this on the other part. I would like to agree with Naledi where she has ended. Definitely, in the context of a novel virus that we're dealing with at the beginning, and it was very, very important that whatever knowledge that would come across, that it is shared quickly with the scientific world and the general population, so that we can be able to reduce the deaths. So in this context, I think it was right for people to try to share the knowledge that they had generated as fast as possible. Now, for WHO, I think one of the reasons that we have always been accused of being slow is that then there's a policy that we cannot change guidelines based on non-peer-reviewed publications. And so even if it sometimes, if it's a peer-reviewed publication, if it is not a methodology that is very strong, we will not change guidelines based on that. So we have to wait for the evidence to accumulate, and we have strong evidence that we can be able to corroborate with different researchers in different parts of the country. So it's a very important process in terms of developing guidance, so that you issue guidance that is scientifically sound and that you don't have to retract. But in a fast-moving pandemic, then sometimes you find yourself behind, because they'll say, no, this evidence came out 2 weeks ago, or there's this preprint that is showing this, but you cannot use that to change guidance, especially when you're producing guidance for all the countries in the world. So that is it. And I think for journalists, it's always very important to ensure that we really double check with the source of this preprint, right? Is it a credible source? Because some of the sources have been known that over the course of this, they have not been producing something that is credible. So we will have doubts about this. And then, like Naledi was mentioning, it's always, you cannot state it as a statement of fact when the paper has not been peer reviewed. And therefore, the headline has to be crafted in a way that you say that this is a potential evidence that has come out. However, this is not yet been peer reviewed, and therefore, when people are trying to consume this kind of knowledge, they should exercise caution in utilizing it. Finally, I think WHO has worked with a number of partners, and I'm glad, I think a number of the people on this platform, the Africa Infodemic Response Alliance, everybody working together to try to ensure that we are correcting the misinformation and we are pointing people into the right direction. It was definitely not a task that the organization could do alone without the different organizations that came on board, that we collectively, because some of the things we may not have the reach happening in different parts of the country, and teams like the one Naledi is working with, they have been very, very effective in trying to address this. So it has been a whole of society approach, but then we try to emphasize for big institutions like the ministries of health and different entities that produce guidance for consumption by the public, to always ensure that they are based on research that has been verified and that has been peer reviewed, and that also is based on a sound methodology that cannot be questioned tomorrow. So that has been the approach, and I think we continue to stand by it. Right now, there's a lot of pressure to change guidance on public health measures, but we are still reviewing the evidence and consolidating and trying to make sure that when we make a pronouncement tomorrow, things won't change, and then we have to backtrack on the evidence that has been given. Thank you.
Thank you, Dr. Otim. And for the final round of questions, somebody is asking how effective rapid tests, in that we've had instances where somebody has tested positive, and when they go and test on the same day, they get different results. And also there are allegations here. Somebody is asking from Malawi, how do you respond to allegations that organizations like yours are suppressing indigenous knowledge of curing diseases, since we cannot find information or studies for the majority of remedies that are found in traditional Africa? And lastly, the BA.2, how different is it from Omicron with regards to the symptoms? And is there a chance of somebody getting reinfected if they had Omicron, and what are the chances of them getting the BA.2? Thank you.
Thank you. Naledi, you want to have a go at any of them?
Okay, I think let me handle the question directed specifically at me. So the question about allegations of us suppressing indigenous knowledge. So I will admit that we are limited in the sense that we can only, our fact checks can only be informed by publicly available knowledge. And so where there is no publicly available knowledge, it's difficult for us to rate something as true or not true. At the same time, though, we are nonpartisan, we are independent, we don't have an agenda. You know, it's not like we're here to, there are some people who seem to think that we're to promote the interests of big pharma, when that's not the case at all. But we do have a responsibility to give our readers information that is based on evidence. So, and we do this in a number of ways. Studies is just one way that we look at evidence, but we will also consult medical experts. And if the consensus across the board, after we've looked at studies, after we've consulted medical experts, is that there is no evidence that a particular cure works, then that is what we need to publish. And we have seen over the years that there has been more of a push to get indigenous forms of medication subjected to the same levels of testing. For example, when Madagascar released their Artemisia-based tonic, I think there was talk about them getting the tonic tested by the WHO, subjecting it to the same medical standards. But you know, there are some people who might see us saying there's no evidence this works as us suppressing medical information, but we do also need to take into account that a number of the cures that we see on social media either at best don't work or at worst may be harmful. And so we do have a responsibility to inform our readers if there is no evidence that something works, if that answers the question.
Thank you. And I would like to start on that point that as WHO actually, specifically in the African region, our regional director has been very, very emphatic on this, that we have to support indigenous knowledge and we have to support African traditional medicine. So actually there is a committee that was set up at the regional office. We have a regional strategy for traditional medicine from 2013 to 2023. So this is started before the issue of COVID. And then there was during this COVID, there was a committee that was set up to bring traditional medicines to trial so that they can get them into a study and be able to demonstrate the efficacy. Now, the issue has been that most of our people, when they come with these medicines or so, have not been willing to subject, and the WHO has always been willing that you have this cure, come with it, bring all your ingredients and so, let's subject it to a committee of experts, of peers that will look at it, and it goes through a trial process so that we can finally verify it and come up with the active ingredients and proper direction of use for this. So they have been working on supporting different researchers and traditional medicine practitioners who have been willing to work on this. But a number of the people just like to make claims, but later when you ask them to come with their products, they are not willing to do that. I would like to give an example, even of African invention. There has been a lot of support for innovation from the WHO Africa region during this time. One of the things, for instance, in South Africa, the team came up with a version of mask, we call it the Oxera mask, and they show that it was very, very effective for use in resource-limited settings. And when they brought it, by then I was still in South Africa, we presented it to the regional committee, we took it to the HQ, and they are now working with the inventors of this in South Africa to see how they can scale up that. So there has been that effort, but I think the people need to just stop making pronouncements and work with the institutions that are there so that their knowledge can be validated and used to help the continent. Now, the second one, in the issue of the rapid diagnosis test, and I would like to state this, that the gold standard for testing for the coronavirus is the PCR test. The rapid diagnostic test is a screening test. And there are different types of rapid diagnostic tests on the market. Some of them are not listed by WHO on the emergency use listing. Some of them, people have just come up with them there. So for each country, whenever they are going to approve the use of an RDT, they go through an evaluation process. And so that they can be able to, there are two parameters that are used. There's the specificity and then there's the sensitivity. So they have to test those in that context to be able to use them. So there's always a room that you will get a false negative with an RDT. And that's why a confirmatory tests for all these is the PCR. So we don't take this, and that's why in a WHO's guidance, we don't recommend the use of RDT in situations where the incidence of the virus or transmission is very low. So you use it as a screening tool in areas where transmission is very some mutations happening. Like I discussed earlier, the more the virus spreads, the more you get mutations. So the BA.2 emerged from BA.1. So there's a difference of about of 60 protein difference between the BA.1 and the BA.2. But in terms of the clinical presentation, the data that has been looked at, there was even one from South Africa, they compared people who have the BA.1 and BA.2. There is no difference in symptoms. There is no difference in hospitalization. However, there is difference in terms of the spread. So BA.2 is more transmissible compared to BA.1. So that's why it is beginning to spread faster and take over. But it doesn't have advantage in terms of disease severity. There's limited evidence to show that now. And also now some research that was done in Norway, and I was just looking at some analysis 1 hour ago from South Africa, there is evidence of reinfection with BA.2 for people who had BA.1. But all of them have been very, very mild. So there has been no severe disease in any of the people that were reinfected with BA.2 after they had BA.1. So the good thing is that it doesn't cause severe disease at the moment. That's the evidence that we have. And it just spreads much faster. And that's the reason why we keep insisting that we cannot drop our measures totally, because the moment any small change happens in the virus, you get a new variant or a sublineage that is highly transmissible than the other one, and it can spread much, much faster. So we still continue to do, and at the moment, we think in the next few weeks, it will overtake the BA.1, but it still remains Omicron. It's just that the two of them are slightly different in terms of their genetic composition. Thank you.
Thank you very much, Dr. Otim. And thank you very much, everybody, for your questions. And it's back to you, Wayne.
Thanks, Tole. Yeah, unfortunately, I think we're out of time for today. I'm sure we could, I have more questions I could ask, but as we wrap up this dialogue, we'll let you know that we're also make this recording of this dialogue available to you, so you can double check your quotes in your reporting on this. We'll also send audio excerpts of this talk out using WhatsApp to make sure everybody gets the latest data on the pandemic in East and Southern Africa. And of course, as always, we'd love to hear from you about how you use the information you gained in today's dialogue. So please keep in touch with us. Send us samples of your work, which would be fantastic, so we can track all of this. Many, many thanks to Dr. Otim Patrick Ramadan and Naledi Mashishi for joining us today. And until next time, for Tole Nyata and the RCCE Media Working Group, I'm Wayne Sharp saying thanks for joining us and stay safe.
Thanks, everyone. That was great. Thank you.